So now we are going to talk about physiological changes in pregnancy. So basically what we'll be looking at are the body systems, that is the endocrine, the metabolism, the hematological, cardiovascular, respiratory, GIT, renal, skin changes, genital or pelvic changes. The aim of this lecture is basically to gain an understanding of the physiological changes that occur during pregnancy. So when you look at pregnancy, it's not something that is abnormal. No, it's a normal physiological process. Our bodies have been designed in such a way as to be able to get pregnant. So when a person is pregnant, it's a normal thing. But then this physiological process comes with profound changes that are produced in the genital tract, in general structure of the mother, and in the function of most organs and systems of the body. Now, these anatomical, endocrinological, and physiological changes are a positive adaptation of the mother in order to accommodate and support the fetus as it grows and develops throughout gestation. So, it's very normal for these physiological changes to take place if we want the new life to survive. And so, because these changes are due to the fact that there's a new life that is being developed, once that new life is born, those changes will go back to how they were in the non pregnancy state. So, the changes are temporal and they do not produce permanent deleterious effects in the mother. Now, these changes that are occurring in pregnancy, they are due to hormonal production, circulation, and metabolism. So you will learn to say during pregnancy there are certain hormones that are produced, and these hormones have a profound effect on certain organs, bringing about those physiological changes. So let us start by looking at the endocrine changes. We obviously know that the endocrine system has to do with production of certain hormones. So the first hormone that we're going to look at is progesterone. Now, this progesterone is produced by the corpus luteum in the first weeks of pregnancy and by the placenta thereafter. So basically what happens is that when ovulation takes place, what remains behind is the corpus luteum, and this corpus luteum is the source of the progesterone. Now, the corpus luteum will degenerate after some time, and so what will now continue producing the progesterone is going to be the placenta. So, what does this progesterone do? Well, the progesterone reduces smooth muscle, stomach motility, and may induce nausea. Okay. Uh, colonic activity is also reduced, and hence there's going to be a delay in emptying of the waste products, right? Also, there's going to be little water reabsorption, and there could also be constipation. There's also going to be reduced uterine tone and diminished uterine activity. There'll be reduced bladder and ureteric tone, and there's going to be stasis of urine. So basically, the progesterone is causing relaxation of the smooth muscle, let's say. And so, because these smooth muscles have relaxed, it means that because for peristalsis to take place, you need to have contraction of those muscles. So now, if contraction is not taking place, then it means that you'll be experiencing nausea because that food is not going downwards where it's supposed to go. And so now, because the peristalsis has reduced, it means that you may have also constipation because that food is taking long to go downwards due to the reduced contractility of the GIT muscles, right? And also you're going to have stasis of urine, because if the bladder is relaxed, then it means that there's filling in of urine and the bladder is not contracting so as to get rid of um there's reduced bladder and ureteric tone, which means that there's going to be stasis of urine. Yes. Now, the progesterone reduces the vascular tone, hence bringing about venous dilatation, and this reduces diastolic pressure. Why? Because when there's dilation of the veins, it means that the the venous return has reduced, and the venous return has reduced. It means that um, the amount of blood that the heart is going to receive will be less, and hence there's going to be little blood being pumped out, hence the reduction in diastolic pressure. Then also this progesterone is responsible for hemogenic changes. It also increases fat storage. It also induces the development of breasts. What about estrogen? So the ovary is a source of estrogen in early pregnancy, but then later on the placenta will produce estrogen and estradiol. The estradiol is the main estrogen, a product resulting from interaction of the placenta and the fetal adrenals. This estrogen is going to induce growth of the uterus and will control its function. The estrogen is responsible with progesterone for development of the breast. It also alters the chemical constitution of connective tissue, making it more pliable, allowing the stretching of the cervix. The joint capsules will relax and the pelvic joints will become mobile. It also causes water retention and it may reduce sodium excretion. What about cortisol? So, maternal adrenals are the sole source in early pregnancy, but later cortisol will be produced by the placenta. This increases blood sugar because we know that cortisol breaks down sugar. So, it will increase blood sugar, it will modify antibody activity, it will increase lipogenesis and fat storage, hence the gaining in weight during pregnancy. Aldosterone, most wholly from maternal adrenals, promotes retention of sodium and water. Insulin secretion rises in pregnancy, but tissue sensitivity is reduced, and this may account for the gestational diabetes. So uh, estrogen rather promotes the secretion of insulin. But then we have other hormones such as the human placental gene, which uh, is which causes tissue resistance to the insulin, and so GDM. Thyroid. So the total serum thyroxine concentration is going to rise during pregnancy. In early pregnancy, serum HCG activates the thyroid gland, and when it peaks between 9 and 18 weeks, the TH secretion is going to fall via a negative feedback. Then the thyroid is going to grow larger. So we basically know to say the thyroid produces hormones such as thyroxine and triiodothyronine. And so now in pregnancy, you have HCG, which also activates the thyroid gland, hence making it produce more thyroxine. Now, because it's activating the thyroid gland and producing these hormones, there's a negative feedback that occurs where TH secretion falls because there's an increase in the secretion of those hormones. But then, despite the TSH falling, the thyroid continues to grow larger. Why? Because the HCG keeps on activating it, it keeps on stimulating it. Now, in spite of The elevated serum thyroxine in most patients are euthyroid. In early pregnancy, serum HCG activates the thyroid gland, and when it peaks between 9 and 18 weeks, TSH secretion falls via negative feedback. The thyroid grows larger. Now, there is an increase in the production of thyroxine binding globulin by the liver, resulting in increased levels of thyroxine and triiodothyronine. Serum-free T4 and T3 levels are slightly altered, but are usually of no clinical significance. These hormones decrease slightly in the second and third trimesters of pregnancy, and the normal ranges are reduced. The free T3 and T4 are the physiologically important hormones and are the main determinants of whether a patient is euthyroid. So serum concentrations of TSH are decreased slightly in the first trimester in response to the thyrotropic effects of increased levels of human chorionic gonadotropin. The thyroid gland is 25% larger in patients who are iodine deficient. Levels of thyroid-stimulating hormone increase again at the end of the first trimester. Upper limit in pregnancy is raised to 5.4 micromole per liter compared with a level of 4.0 micromole per liter in the non-pregnant state. Pregnancy is associated with a relative iodine deficiency. This is caused by active transport of iodine from the mother to the fetal placental unit and increased iodine excretion in the urine. So during pregnancy, there's going to be increased excretion of the iodine via urine, and then also there's going to be an active transport of this iodine from the mother to the fetal placenta unit. Hence, the reduction in the iodine resulting into iodine deficiency. The World Health Organization recommends an increase in iodine intake in pregnancy from 100 to 150 to 200 milligrams per day. If iodine intake is maintained in pregnancy, the size of the thyroid gland remains unchanged, and therefore the presence of goiter should always be investigated. What about the parathyroid hormone? So the parathyroid hormone increases due to calcium decrease because of increase in fetal calcium. Remember, the parathyroid hormone is the hormone that is responsible for maintaining normal calcium levels. So in a situation where you have reduced calcium, this hormone is going to be produced so that it should bring back calcium homeostasis. Now, why is calcium decreasing in pregnancy? It is because it is being transmitted or transported to the fetus. The human chorionic gonadotropin hormone, HCG, is produced by the trophoblast with peak levels at 16 weeks. Thereafter, it remains constant. Main function is maintenance of the corpus luteum, has thyrotropic action, and seems to initiate testosterone secretion from the Leydig cells. Then the human placental lactogen is lactogenic and antagonist to insulin. It helps reduce deamination of protein. Relaxin is secreted initially by the corpus luteum. It relaxes the cervix, inhibits uterine contractions, and relaxes the pubis symphysis. Peripheral joints become lax, ligament laxicity, and contributes to low back pain and vulnerability to injury during mechanical stress of labor. The pituitary gland hormones, maternal follicle stimulating hormone and luteinizing hormone, are suppressed during pregnancy, but prolactin levels rise throughout. HCG and the gonadotropins share a common alpha subunit, and the rapidly rising HCG suppresses secretion of both FSH and LH, thus inhibiting ovarian follicle development by a blunting of response to gonadotropin releasing hormone. Lactation does not start despite the increase in prolactin until delivery, when the high prolactin persists in association with the falling estrogen levels. Let us take a look at metabolism. So when it comes to carbohydrates, the weight increase of 12.5 kg, the main increase occurs in the second half of pregnancy. The total nutritional calorie requirement for whole pregnancy is 3,600 kilojoules per day. Remember, you're eating for 2 people. But then if it so happens that your caloric intake is less than 1,200 kilojoules per day, then you can get supplements. Pregnancy is a diabetogenic state, and the adaptations in glucose metabolism allow shunting of glucose to the fetus to promote development while maintaining adequate maternal nutrition. Insulin-secreting pancreatic beta cells undergo hyperplasia, resulting in increased insulin secretion and increased insulin sensitivity in early pregnancy, followed by a progressive insulin resistance. These hormones cause a decrease in insulin sensitivity in the peripheral tissues such as the adipocytes and skeletal muscle by interfering with insulin receptor signaling. The effect of the placenta hormones on insulin sensitivity is made evident postpartum when there is a sudden decrease in insulin resistance. Insulin levels are increased in both the fasting and postprandial states in pregnancy. Fasting glucose levels are, however, decreased due to increased storage of tissue glycogen, increased peripheral glucose use, decrease in glucose production by the liver, and uptake of glucose by the fetus. Maternal insulin resistance begins in the second trimester and peaks in the third trimester. This is the result of increasing secretion of diabetogenic hormones such as human placental lactogen, growth hormone, progesterone, cortisol, and prolactin. Insulin resistance and relative hypoglycemia results in lipolysis, allowing the pregnant mother to preferentially use fat for fuel, preserving the available glucose and amino acids for the fetus, and minimizing protein catabolism. The placenta allows transfer of glucose, amino acids, and ketones to the fetus but is impermeable to large lipids. If a woman's endocrine pancreatic function is impaired and she is unable to overcome the insulin resistance that is associated with pregnancy, then gestational diabetes develops. So when it comes to proteins, the overall picture is one of positive nitrogen balance. Peak values reached at 28 weeks and by end of pregnancy 500 grams retained. Pregnant women require an increased intake of protein during pregnancy. Amino acids are actively transported across the placenta to fulfill the needs of the developing fetus. During pregnancy, protein catabolism is decreased as fat stores are used to provide for energy metabolism. What about fat? Fat is the main form of maternal stored energy. 4 kg stored by 30 weeks as depot fat in the abdomen, wall, back and thighs, and perhaps retroperitoneally. Blood fat increases from third month. Total lipid at term is about 1050 grams per deciliter, and total cholesterol is about 7.2 millimoles per liter. Ooh. So let us now take a look at the circulatory system. What changes are going to occur? So cardiovascular changes occurs in early pregnancy such that by the 8th week of pregnancy, cardiac changes would have increased by 20%. The cardiac output increases by 40 to 50%. This is a result of the fall in the peripheral resistance. Cardiac output increases progressively throughout pregnancy. Increase in stroke volume and also increase in the heart rate. Cardiac output reaches a maximum at 20 to 28 weeks gestation. There is a minimum of 4 at term. Blood pressure decreases in the first and second trimesters but increases to non-pregnant levels in the third trimester. Stroke volume is the amount of blood that is pumped out of each ventricle per beat. That is 70 mL from each ventricle. Cardiac output is the output per unit time. That is 5 liters per minute. Veins are called capacitance vessels because a large amount of blood can be added to the venous system before they become distended to the point where further increments produce a large rise in venous pressure. At rest, 50% of the circulating blood volume is in the systemic veins. Pressure in the aorta, bronchial, and other large arteries rises to a peak value of about 120 millimeters of mercury during each heart cycle and falls to a minimum value of about 70 millimeters of mercury. The pulse pressure, which is the difference between the systolic and diastolic pressures, is normally about 50 millimeters of mercury. Pressure falls very slightly in large and medium-sized vessels, but rapidly in small arteries and arterials. The main sites of peripheral resistance against which the heart pumps. Yes, the arterials, these are the main sites of peripheral resistance. And that's the reason why we are seeing an increase in the blood pressure because of the rapidly decreased pressure in the small arteries and arterials. Arterial pressure is a product of the cardiac output and the peripheral resistance. So increases in cardiac output increases systolic pressure, whereas increases in peripheral resistance increases the diastolic pressure. Central venous pressure and pulmonary capillary wedge pressure remain stable throughout pregnancy. Colloid on-contact pressure decreases by 14%. Pregnancy amplifies the first heart sound. Nearly all have a splitting of the first heart sound. Respiratory variation of the second heart decreases. By the 20th week, a third heart sound may be heard. A systolic ejection murmur may be present in most women and a diastolic flow murmur may be heard in a few. The onset of these murmurs correlates most closely with rises in blood volume and not cardiac output. The changes in heart sounds usually resolves within 4 weeks after delivery. Labor is associated with further increases in cardiac output. Uterine contractions lead to an auto-transfusion of 300 to 500 ml of blood back into the circulation, and the sympathetic response to pain and anxiety further elevates the heart rate and the blood pressure. Cardiac output is increased between contractions, but more so during contractions. Maternal systolic and diastolic blood pressure increases 10 to 20 millimeters of mercury during a contraction. Following delivery, there is an immediate rise in cardiac output due to relief of the inferior vena cava obstruction and contraction of the uterus, which empties blood into the systemic circulation. Cardiac output increases by 60 to 80%, followed by a rapid decline to pre-labor values within about 1 hour of delivery. Transfer of fluid from the extravascular space increases venous return and stroke volume further. So over here we have a summary of the cardiovascular changes. So there's going to be an increase in blood volume, increase in cardiac output, increase in stroke volume, increase in end-diastolic volume, increase in the rest and pulse, and increase in the percentage of blood plasma. But we are going to have a decrease in hematocrit, decrease in blood pressure, decrease in blood supply to the uterus, decrease in cardiac reserve, a decrease in vascular resistance. So there is what we call supine hypotension, which is related to vena cava syndrome. So basically what happens is that when a woman lies on her back, she compresses on the vena cava, hence reducing venous return, and hence you have the supine hypotension. So this can lead to dizziness, air hunger, and nausea. In the supine position, pressure of the gravid uterus on the inferior vena cava causes a reduction in venous return to the heart and a consequent fall in stroke volume and cardiac output. Turning from the lateral to the supine position may result in a 25% reduction in cardiac output. So pregnant women should therefore be nursed in the left or right lateral position wherever possible. What about the total body water? It increases to about 6 to 8 liters. So it definitely increases by 40%. The normal body water is 2/3 intracellular, 1/3 extracellular, 3/4 interstitial, 1/4 intravascular, 2/3 increase in extravascular. What about hematological changes? So blood values, red cell mass is going to increase by 18% only compared to the plasma volume. This leads to a hematocrit that is less than 40%. The Hb concentration and red cell count will reduce from 4.5 to 3.8. However, there is a rise in total circulating Hb directly related to the increase in the red cell mass. Leukocytes are markedly increased in late pregnancy, and these are entirely polymorphs. So let us talk about physiological anemia of pregnancy. So this is basically due to physiologic intravascular change. The plasma volume increases by 50 to 70% beginning by the 6th week, while the red blood cell mass increases by 20 to 35% beginning by the 12th week. So there's a disproportionate increase in the plasma volume over the red blood cell volume, resulting in hemodilution. Now, despite erythrocyte production, there is a physiologic fall in the hemoglobin and hematocrit readings. Hemoglobin stays the same initially. It may drop down to 10 and still be normal physiological anemia. Normal pregnancy HB is 10 to 14, and that is later in pregnancy. Then you have a decreased hematocrit of about 38 to 47%. The normal pregnancy hematocrit is 32 to 42 later in pregnancy. The pulse rate may increase 10 to 15 beats. What about iron deficiency anemia? With erythropoiesis of pregnancy, iron requirements increase. Now, because large amounts of iron may not be available from body stores and may not be in the diet, it will result in iron deficiency anemia. Supplementation is recommended to prevent iron deficiency anemia. At term, hemoglobin less than 10 is usually due to iron deficiency anemia rather than the hemodilution of pregnancy. So what are the normal iron requirements? So the total body iron content average in a normal adult female is 2 grams. Iron requirement for normal pregnancy is 1 gram. Why? Because 200 milligrams is excreted, and that's the one that we supplement with. We give them 200 milligrams of ferrous sulfate. So 200 milligrams is excreted, 300 milligrams is transferred to the fetus, 500 milligram is needed for the mom. Okay, why? Because total volume of a red blood cell is 450 ml. 1 ml of red blood cell contains 1.1 milligrams of iron. Okay, so which means 450 ml will require 500 milligrams of iron. Ooh. So daily average is around 6 to 7 milligrams a day. Small intervals between pregnancies are most concerning. What about coagulation changes? Changes in the coagulation system during pregnancy produce a physiological hypercoagulable state in preparation for hemostasis following what? Delivery. Pregnancy activates the clotting system. The concentrations of certain clotting factors, particularly 8, 9, and 10, are increased. All factors except 11 and 13 will go up. More significant increases are seen with factors 7, 8, and fibrinogen. Fibrinogen levels rise significantly by up to 50%,